Okay, thank you, Bennett. So we're going to have a session today morning discussing some issues with regards to acute and chronic pancreatitis, pancreatic fluid collections, assessment of cysts in the pancreas, and getting a surgeon's perspective and having some information on how to better access the biliary tree during your RCP. So we're excited to have our speakers in our panel this morning, and starting off will be Dr. Alireza Sedarat, our newest recruit to our interventional endoscopy faculty. Ali's a former fellow in our division and did his advanced fellowship at the University of Pennsylvania. And he's going to talk to us about chronic pancreatitis and managing complications. Ali?
Good morning, ladies and gentlemen. We'll go ahead and get started. Here's my disclosure slide. A lot of these slides are from the ASG and the AGA, and I'm going to be referring to the European guidelines, which recently published a paper about 2012 on the management of chronic pancreatitis, which I encourage you to look up online. So as an overview, we're going to briefly touch on a little bit of background. We'll talk about what the complications are, but primarily, because we have some limited time, focus on the endoscopic treatment of the complications of chronic pancreatitis. A couple of things to keep in mind as we go forward. Recognize that chronic pancreatitis is a spectrum of disease. It's something to be approached with your colleagues, surgeons, interventional radiologists, gastroenterologists, internists, together. It's not something that you necessarily want to tackle alone as an island. Selection of the patients, individualized approach is really important with these patients. No two patients are the same, and the approach should be individualized. And we're going to focus again on the endotherapy. So some working definitions. Chronic pancreatitis is a permanent and irreversible damage to the pancreas of various causes. It's characterized by a histology of a chronic inflammatory infiltrate and fibrosis on the slide there. You see a calcification in a ductule. And clinically, it's characterized by progressive loss of both exocrine and endocrine function, and a spectrum of clinical morphological and functional abnormalities that cause sometimes debilitating consequences. Again, it's a spectrum of disease, and severe pancreatitis is a no-brainer. You know, calcifications are present or a markedly abnormal duct, and it's relatively easy to diagnose. When there's minimal or mild change, it's a little harder. When there's discordance from structural or functional tests, it's a little harder to diagnose. And it's important to kind of keep this in mind as you're deciding how to treat a patient. Am I really dealing with chronic pancreatitis, or is it something else? And when we talk about therapy, surgical, medical, endoscopic, a major distinction between small duct versus large duct disease should be kept in mind, with a cutoff roughly of 5 to 6 millimeters of the main duct in terms of what you select for therapy. So the diagnosis, anytime you have a slide of how to diagnose something and there's this many tests on there, you know it's a hard diagnosis to make. There's structural tests, there's functional tests. We won't go into details, but the bottom line is there's not a gold standard, and it's a clinical diagnosis. Some of the complications, obviously there's lots. Pain is probably the most debilitating and what most people are going to come see you for, and it's complex, and it's not just that the pancreas is inflamed. It's a complex interplay between the CNS and the viscera. There's obviously exocrine and endocrine issues. There's dysmotility that can mimic gastroparesis. Local effects we'll talk about, specifically biliary obstruction. Dr. Watson is going to talk about some fluid collections. There's unique bleeding complications that can be lethal. And of course, malignancy should always be kept in the back of our minds anytime we deal with these patients. A little bit of just the natural history as we talk about these. Early in the course, patients have primarily pain, and as it burns out, so to speak, there's good natural history data that the functional issues become more dominant and pain becomes less dominant, though it doesn't always necessarily disappear. So let's talk about the pain. So lots of causes of pain. There's direct neural inflammation, ischemia of the gland, fluid collections and pseudocysts, intraductal hypertension, local inflammation, local organ duodenal CBD obstruction. Most of the endotherapy focuses on intraductal hypertension and improving flow. We have to remember, however, that it's not just the pancreas in these patients that may be a cause of abdominal pain. They're at risk for other issues, and I would highlight especially narcotic-related pain syndromes. Something that we may talk about later with the functional disorders is chronic abdominal pain in general, and chronic pancreatitis in specific isn't necessarily a abdominal pain syndrome in isolation. There's, as we're learning more and more, complex interactions between the viscera and the CNS in chronic pain syndromes. And we all probably have heard of or seen a patient who's had a total pancreatectomy with an auto islet transplant and still has the same pain. And so I think that's fascinating and makes it very challenging to deal with these patients. So let's start talking about endotherapy. So what we have available for us is an array of interventions. There's usually a pancreatic sphincterotomy involved, various degrees of stricture stenting and dilation, stone removal, stone destruction, and more often than not, a combined approach is taken. So in that pancreatogram, you see a dilated duct. There's a stone in the head, and there's a stone in the tail. So the approach. Patient selection is the most important thing. Whenever you look at studies that are comparing different modalities, looking at the population is important. How severe is their pancreatitis? What is their etiology of their pancreatitis? So that's something you should really kind of keep an eye on. The rationale, it works, it's repeatable, it doesn't hinder surgery, it may predict response to surgery, and if someone has significant cardiovascular comorbidities, isn't a good operative candidate, has significant comorbid portal hypertension, which is often comorbid, it's a good alternative. So this is from the European guidelines, kind of summarized some long-term follow-up, and I've kind of put these numbers together. Roughly 2,000 patients, roughly 6 years, about a quarter maybe go on to surgery, 15% over the follow-up still need some kind of endoscopic therapy, but significantly in these long-term series, and these are carefully selected patients, 2/3 of them are doing well without further treatment, and we should keep that in mind. So the approach to PD strictures. In general, I think the most important thing if you're looking at a PD stricture, whether you see it on an MRCP or a CT scan or an ERCP or an EUS, is it benign? And every time you look at it, ask yourself, is it benign? There's a high risk of occult malignancies, both of adenocarcinoma and, frankly, IPMN masquerading as chronic pancreatitis. So amenable strictures, they're focal in the head or the neck, associated upstream dilation. If you have complex strictures that are associated with a high stone burden, side branch strictures, diffuse stricturing of the gland, or some other associated complications, those may not be the best to attack. So the approach is usually pre-dilation, either with a balloon or with catheter-based tapered dilators. Raman has a nice technique of screw dilating strictures and coring them out, which works. And then stent placement. Some would argue for multiple stent placements, similar to the approach for OLT strictures. And then at some point, exchanging or adding stents over a period of a year. And typically, the conversation to have these patients is you can expect to have several procedures over the course of a year. This is not a one-and-done type of a deal. And at some point, you try without a stent, keeping in mind that a fluoroscopic resolution of stricture is not necessary for pain relief, and that's an important thing to keep in mind when you deal with these patients. And then obviously, if their pain recurs, you either go back to endoscopy or refer to surgery as needed. In terms of what stents to select, generally single versus multiple. Multiple may be better, and there's at least one good series that addresses this. Sizes range anywhere from 3 French to 11.5 French, with typically in the 5 to 7 French size being used. The stents are generally sized to the downstream portion of the duct, the non-dilated area. There's a variety of stent designs. I prefer single-flanged, single pigtail stents. Plastic, usually metal should be considered investigational, and there's not much data about its use. It's very important if you're going to place a pancreas stent for whatever reason that you don't place it backwards. If you do, especially if you decide to modify it by cutting off a flange, and these are tiny things that you may not kind of see how it's being handed to you. If you load it backwards, the likelihood is that it will migrate inward, and it'll be a little bit of a problem. So here's kind of the summary of the world literature, if you like, of strictures. The technical success is very high. The pain relief is somewhat less, but still relatively high. Sustained relief in about 2/3. The follow-up is very variable among studies, and I think that's very important to keep in mind when you read these studies. The complications, roughly 20%. That includes pancreatitis, stent migration, infection, and 1% mortality. So it's not necessarily low-risk procedures, and we need to keep that in mind. So moving on to stones, and I've just to take a step back, separated stones and strictures and things like this, but you're usually dealing with all of these together at once, and we should realize that combination therapy is usually necessary. So roughly a third to one half of patients have stones, but stones don't necessarily equal the cause of the pain. They may be an epiphenomenon, especially considering some etiologies of the chronic pancreatitis. So some patients that have tropical fibrocalculus disease, they tend to have larger stones, denser stones. They're younger patients. These are the series that are coming out of India, for example, very high quality and impressive series. But they're different patients than we may deal with typically here. And anytime you read a study, that's important to kind of keep in mind. Another thing to keep in mind is PD stones are not the same as dealing with CBD stones. They're more difficult to remove, less successful, and with associated higher complications. And so I think the techniques are a little bit more involved there. So the approach, something that's in the head as opposed to in the tail is more amenable to removal. Something that's associated with some dilation. Extensive stone burden, stones that are adherent or impacted, stones behind strictures, stones inside branches, complex or long strictures that are going to inhibit your removal, or maybe things that are more difficult or shouldn't be tackled endoscopically. So the technique, usually sphincterotomy that's big enough to pull the stone out, stricture dilation, and some kind of lithotripsy is often attempted, especially for larger stones, either mechanical, S-wall, or intraductal. Mechanical hasn't really been touched on too much. I think people are hesitant of getting stuck with a stone because they're usually harder. And then removing with a balloon or a basket. I think a basket's better for sweeping the pancreas duct because a balloon tends to often kind of redirect fragments into the dilated side branches as you're sweeping, and a basket, may be more effective at avoiding that. So just a few touch about S-wall. It's extracorporeal shockwave lithotripsy, if you're not familiar. It's a technique of basically extracorporeal shockwave directed at the pancreas. It's available at a few centers. Usually there's some kind of interaction with the urology department to get this technique. It's more available in specific centers and centers outside of this country. It has a very high fragmentation rate. It's usually combined with endotherapy, but there's at least one good series that uses it as monotherapy, and it's probably especially effective in the absence of significant stricture burden. It's not been directly compared to endoscopic lithotripsy, such as EHL or laser lithotripsy, but I would consider that, in hands where you do have cholangioscopy or spyglass available, an alternative, and we've had some success with that. In a meta-analysis of about 600 patients, it was relatively effective at both pain relief and duct clearance. So one thing to keep in mind if you're going to tackle these, there are some features. If you're not sure if you can tackle a stone, do I need S-wall? Do I need to consider lithotripsy? These are some favorable features of a stone on pancreatogram or on an MRCP that you can look for that may suggest you'll be okay with just standard, if you like, therapy without lithotripsy. So just to summarize again some stone data, stone clearance in 2/3 to 3/4. The clearance is higher when it's combined with S-wall. The pain improvement is pretty impressive, 75 to 85%, and sort of a mild to moderate rate of complications, primarily pancreatitis. So what we're going to probably talk about on the panel at some point, and so I'm going to preempt it, so I have a little bit of a bias, I'm sure, but often it becomes a question of, I have someone with severe disease, I think it's amenable to some kind of a therapy. What do I do? Do I send them to a surgeon or an interventionalist? We have now 2 randomized controlled trials published that favor surgery. We'll go through those a little bit. On the other hand, we have lots and lots and lots and lots of case series from different countries with lots of patients that show that there is a benefit to endoscopy, and it's a good modality. And these are, again, kind of a theme here, carefully selected patients. And we have also case series and retrospective series that question the permanence of the surgical solution, specifically drainage and resection procedures. In the back of my mind, usually I have an idea of a warranty of about 5 to 7 years for like a Pusteau or something like that. And I'd be curious what Dr. Hines may comment on that. But I think the goal here is really, when you sit down and talk to a patient, to present options and to present the risks and benefits of each and try to talk about their likelihood of success. If they're going to go the endoscopy route, they need to understand that they're going to be your friend for at least a year and have to follow up. And if they don't, if you don't think they're a good candidate to follow up, maybe that person isn't the best candidate for endoscopy. So this is the first randomized controlled trial in endoscopy in 2003. I don't know if it's DITE or DITE, I think it's French. 72 patients, 5 years follow-up, and in general, the surgery group did better. But this was criticized somewhat because the endoscopic group was somewhat suboptimal. About half of the patients that were in the endoscopic group received a sphincterotomy only, essentially, which is probably not adequate. Secondly, the surgery group in this first RCT was primarily 80% resection operations, as opposed to drainage operations, which seems to be more of the vogue now. So this was the second one, the follow-up to this, to try to answer some of these criticisms in the New England Journal in 2007. This got a lot of press. It was a small study. 39 patients is not a lot. It was 2 years, but the pain scores did favor surgery, and complete or partial pain relief also favored surgery. And significantly, this study was stopped early because of initial difference that favored the surgical group. However, this also has gotten, and actually when you look this up on PubMed, it's really interesting. You have the reference in the abstract, and under it there's 6 or 7 or 8 endoscopists that just berate this paper, which is kind of interesting. But some of the criticisms that come out of those editorials, small number, the patient selection, a lot of these had pretty high stone burden, and as we talked about, a lot of stones makes it difficult for endoscopy. A lot of these patients had advanced disease. A significant portion had exocrine and endocrine deficiency, which is a surrogate for advanced disease. And their endoscopic approach, although more aggressive, they combined it with lithotripsy, they combined it with dilation, although the dilation was optional. It was an interesting, they placed a 10 French biliary stent as opposed to pancreatic stents, which, although there's never been direct comparisons, if you're not familiar, the biliary stents are just a straight tube with flanges. Pancreas stents have side holes, and the pancreas, as we know, has side branches. And so, the use of a large French without side holes may have contributed somewhat to that outcome. And the stent duration exchange was not necessarily in line with what everyone practices. Somewhat moderate duration and an exchange interval that seemed to be less aggressive than what some people would do. They actually followed up in 2011 their cohort in gastro. 31 of their patients were there. The endoscopy group had a lot more additional treatment, and about half of the endoscopy group, which was about 9 patients, went on to surgery. My argument there is going to be that half of them didn't go on to surgery, which I think is important to realize. The pain scores that they used, the Zbicki scores, were no longer significantly different, but the partial or complete pain relief still favored surgery. There's some nerve-directed therapy that we can talk about. I think this is something that can be offered, primarily a block as opposed to a neurolysis. The outcomes are modest and I would say temporary. But if you have a desperate patient or if you maybe want to give it a shot, a block is maybe not a bad idea. So let's talk about the local effects, and by that primarily I mean biliary obstruction. A variety of causes here: inflammation, fibrosis, pseudocyst tumor. And I'll take a stop here because I hear you shuffling. So I apologize. I kind of shuffled some of the slides because of time constraints. But I put in a lot. Nothing is new that's in these slides, but you have a lot of information in your syllabus regarding medical therapy, some trials, and some extra reading for you on your own there. So the presentation for biliary obstruction, cholestasis, and pain. It can happen in up to a third of patients, which is significant. And they can be complicated in about 10% with cholangitis and significantly biliary cirrhosis, which in some series was actually reversible with surgical decompression. And the treatments there are either bypass or stenting. So the indications are really symptomatic or elevated LFTs, and you're concerned for progression into cirrhosis. So when you're trying to decide about surgery or endoscopy, high stone or calcification burden in the head may predict failure of endoscopy. If someone has significant portal hypertensive comorbidities, surgery may be a bad option. their likelihood to follow up with endoscopy is very important. And those patients in these series, up to 7% died from biliary sepsis because they were lost to follow-up, and that's important to realize. And if they previously failed endoscopic therapy. So your choice, you have kind of, again, an array of things to pick. Single stents, multiple stents. Again, the approach is similar to OLT strictures, parallel stents, as many as you can fit over a period of time. And then covered or uncovered or partially covered stents. I would say that uncovered stents probably don't have a role for benign biliary strictures. And there's some good data that multiple stents are probably better. And these are obviously carefully selected patients, but over what I would say a modest follow-up, they do relatively well. There's some smaller studies looking at metal stents. They seem to do well. I think the take-home is that it's an option. You have to follow up and remember to take them out at some point. What that optimal time frame is unclear, maybe on the order of 3 to 6 months. I had a patient that was referred to me at the VA who had a metal stent placed in 2007 and eventually got a cholangitic abscess. And so now we're trying to figure out how to get rid of that stent. So we'll probably do a stent-in-stent technique to get that out. Duodenal obstruction, just kind of to touch on, duodenal stents don't work as well here. And, if they really have an obstruction, surgery is probably the way to go through gastrojejunostomy or combined with pancreatic resection. So malignancy, we really want to kind of talk about this. The risk is elevated, 3 to 15 times increased. The longer you have pancreatitis, the higher your risk. And it's one of those things, kind of like HCC and cirrhosis. Whenever you have a chronic pancreatitis patient that changes, you should think about cancer. And if only the EUS in a chronic pancreatitis patient was this easy, it would be fantastic. You see a nice, well-defined hypoechoic mass and you FNA it. The problem is that you have an abnormal gland with heterogeneity, calcifications that may be obscuring or shadowing. And so the EUS, although the preferred test, is not perfect and may miss things. So you have to have a high index of suspicion. Don't be afraid to repeat the EUS or refer to a colleague. And I think no one is ever going to fault you to look again for a cancer. And so kind of when do you want to suspect that is basically that something changes that was unexpected. And we all kind of from our internal medicine training know about the association of depression and DVTs. But any kind of a change you want to just kind of keep in the back of your mind is cancer present. Bleeding complications, just very briefly I'll touch upon isolated gastric varices. These are classified as IGV-1s. They often don't bleed, but when they do, it can be severe. And the treatment is splenectomy, or if it's available to you, glue injection or other tissue adhesive injection. So I'm going to stop there and refer you to the syllabus for some other data. And if you have questions about medical therapy, enzymes, things like this, we can certainly talk about that. But just some things to kind of take home as we progress in our talks. Chronic pancreatitis is a spectrum. It can be difficult to diagnose. Emphasize multidisciplinary management. And whenever you're evaluating a patient or a study, your population or your selection of your patient really, really matters in terms of your success. And what you ultimately choose should be tailored to the specific patient. That's it. Thanks very much.